think is intellectually a very elegant and appropriate one. Practically is a very difficult one because in real life, every state of our 50 states is going to make a different decision in terms of priorities within the groups, group 1 or group 2, for instance. And therefore, the companies and the clinical trial sites are going to be scrambling to appropriately provide the vaccine to the right subpopulation within each state. And then the third reason, which I think is also very important, is that there are vaccine doses that have been planned for this. Their stability lifespan is limited. By not immunizing the full population at this stage, we are going to lose the opportunity of using these vaccine doses, which are different than the vaccine doses that are being distributed, and different, simply different batches, and they are not counted as part of the EUA doses. They are part of the clinical trial material. And we would lose the opportunity to immunize quite a sizable number of individuals without competing with the rest of the population. And all of this, if we do it, should incent more people to participate in the upcoming clinical trial or ongoing clinical trials, because it will remain true probably for the next 2 to 3 months that participating in a clinical trial is a faster way to access vaccine than otherwise. That's my opinion. We'll see what the FDA and what the companies ultimately will decide. Thank you for the
The holidays are a time for giving.
To your friends.
Your family.
To your teacher.
In that spirit of giving,
Chevy's proud to give our employee discount to everyone.
the Chevy price you pay
Is what we pay.
Not a cent more.
because giving and giving back is what the holidays are all about.
Use the Chevy employee discount for everyone to get a total value of over $8,400 on this Silverado.
Get the Chevy employee discount for everyone today.
question. Next question.
Thank you. Our next question here will come from Tom Howell with Washington Times. Tom, your line is now open.
Hey, thanks for doing the call. Can you give us an update on the long-term care facility partnership with CVS and Walgreens? How many sites have they reached so far, and what kind of impact do you expect this effort to have on mortality rates since nursing homes have been hit so hard by the pandemic? Thank you.
So I can answer the first part. I'm not qualified to answer the second part. So we've been in 12 states, 238 facilities have been executing this week, and really tremendous effort in getting everybody done. I mean, Walgreens and CVS are being received by cheering crowds. And they're operationalizing their efforts to make sure everybody gets the shots, et cetera. Really important to note, it is a big effort, as those 70,000 total. I see us multiplying capability and capacity every day as we go, and more vaccine becomes available. For example, we already know that next week, that we are going to be in close to 13 additional states with another 1,000 facilities that will start to enter. And every week, we're just building on that as we go. Remember, it's based on the governor's state's plans, right, as they're working through both frontline healthcare workers, and then the long-term healthcare facilities. So it's a mix in the strategies, and we're enabling their plans.
As regard the second question, part of the question, the vaccines, whether the Moderna or the Pfizer vaccine, achieve their maximum level of efficacy within 14 days of the immunization, and then with the second dose, probably that immunity is further reinforced and prolonged in terms of its persistence. Of course, we did not have an outcome on prevention of death, but we did have an outcome in both trial on prevention of severe disease, 100% for both vaccines, and I think it's reasonable to assume that will translate into prevention of death. And therefore, within 2 weeks from starting to immunize subjects that are living in long-term care facilities, we should start to see a decrease in the overall mortality in the country, even that the last time I looked, about 50%, unfortunately, of the total death toll associated with the pandemic came from those populations. The priority should be to maximize the number of individuals that are immunized in the long-term care facilities if we want to decrease the death toll associated with the pandemic. Clearly, these are decisions that are ultimately made at the state level. There are enough vaccine doses to immunize the more or less 3 million individuals that are living in such facilities at this stage. Thank you. Next question, please.
Thank you. Our next question here will come from Rachel Rubin with Politico. Your line is now open.
I was wondering if you guys could give an update on the allergic reactions in the Pfizer vaccine. One, if you have a total of how many reactions there have been and in how many states, and also if there's any more information about what the reaction is to. And also just real quick on the syringes, since there can be extra doses, are you guys sending extra syringes in the ancillary kits? Thank you.
Thank you. Maybe I'll take the first part and then the ancillary kit, maybe General Perna can address. In terms, so I have not had an update today. Yesterday, there were 6 cases on a denominator that we know is lagging by 2 to 3 days. Today's denominator is about 1 million subjects immunized. It may very well be substantially more than that. That frequency, as it stood yesterday, is superior to what one would expect with other vaccines. We would have expected in the range of maybe one person having an allergic reaction, anaphylactic reaction, as it has occurred with the Pfizer vaccine. I'm unaware of any reports associated at this stage with the Moderna vaccine. In regard of what's happening, there are discussions with the companies in the NIH to consider running clinical trial in highly atopic, very allergic subjects that, for instance, have to carry an EpiPen with them all the time or have very significant non-atopic reactions, to immunize them with this vaccine and potentially other vaccine and compare the rate of reactions, but also critically be able to harvest serum and blood cells, etc., to analyze their immune status prior and potentially after such reactions may happen, if they happen. I think that's really the way to try to understand exactly the mechanism. What is it that's provoking these reactions? Is it a true anaphylactic shock? I think we're not clear if that's the case. Is it a mast cell degranulation, which is one of the ways by which we can have this kind of reaction that's associated with the fact that we have particles that are injected? Is it something else? Is it antibodies to the polyethylene glycol, or PEG, as it's known? In which case, this may be different from one vaccine to the other because they're using different format of the PEG. These are only important scientific questions that could be addressed into this clinical trial. It's being discussed as a priority because clearly time is important. But at the same time, we will continue to monitor this reaction. Now, 6 cases out of 300,000 or a million subjects immunized, I think, while important to understand, still does not change the safety profile of this vaccine, particularly now that we know that those reactions can happen, and therefore immunization sites are equipped with the right medicines and interventions to help subjects if and when they have such reactions. I'll pass on to Jonathan in regard of the ancillary packs and the, I assume it's the 6 dose per vial question.
So with respect to the ancillary kits in support of the vaccine in this, in your question, the 6th dose, if available, we put extra capability in the kits, right, so that we would have an overage just a little naturally, as well as combining most of the administration going on right now is in major hospitals, et cetera, where they have access to syringes and needles accordingly. We have adjusted our contract and our construction of the kits to be to even provide even more capability as we go forward. If they choose to, if 6 doses still continues to be available down the road. So feel very comfortable with the availability of syringes and needles and our ability to put these kits together and continue the simultaneous distribution of the kits with the vaccine. Thank you.
Thank you. Our next question here will come from Angelica Levito. Angelica, your line is now open.
Hello, this is Angelica Levito from Bloomberg News. Question for you, General Perna. What do you make of the fact that about 1 million of the 9 million available doses have been administered so far? And are there any actions the federal government can take if you feel like the vaccination is moving too slowly?
So I'll start, and I think maybe Dr. Salawi might be able to help me a little bit as we go. First of all, I think it's a very good pace as we observe. We know the states have a very, all of them have a very good plan. It's a, it's a deliberate plan. It's about access to the vaccine when it arrives and then execution. And we feel very strongly that they really, really have set up and they're immunizing quite a bit of people. As Dr. Salawi mentioned earlier, there's a lag in the information as it's collected from all the really thousands of administration sites. And we know that there's probably at least 72 to 96 hour lag in the information uptake. With that said, we are in collaboration. We talk every single day with jurisdictions to make sure that we're facilitating their plans and where best to add capability and capacity to help them, either through maybe pharmacies or extended use of distribution sites. So I do believe that'll progress here quickly as the two things come together. But Dr. Slawi, anything to add to that?
I think you covered it. You covered it very well, General Perna. I think it's important that the states are able to increase the cadence of immunization, but it's also important that they do it at a pace where they are in control and that no mistakes are made or no accidents are happening. That's super important, particularly at the start. And we are, of course, here to hear their asks and specific demand in how we can help them.
Thank you.
Thank you. Special.
Operator, next question, please.
Thank you very much. Our next question here will come from Peter Loftus. Your line is now open, Peter.
Hi, it's Pete Loftus from the Wall Street Journal. In the past, you've talked about, I think, getting to 100 immunizations by the end of February or by March, and that in the second quarter, I think anyone who wants one could get vaccinated. But I'm wondering how you get there. Is it with increasing supplies of these first two vaccines, or does it depend upon the introduction of a third or even a fourth vaccine?
I'll take that. So the 100 million immunizations can be achieved with the 200 million doses of vaccine for Moderna and Pfizer that both companies are committed to deliver between now and the end of the month of March. Immunization is completed after 2 doses, and there are approaches where we may be able to accelerate the delivery of the doses to the middle of the month of March. The full immunization may actually depend to be achieved by the month of March, depending on whether there are delays in the delivery of the last doses from Moderna or Pfizer. Could depend on the approval of the Janssen's vaccine. As I said in my introduction, that's a 1-dose vaccine. We have completed recruitment in the study. There are cases accruing, very significant number of cases. It's very likely that there will be an analysis, maybe either an interim analysis or a final analysis on efficacy. We are very hopeful, based on the efficacy observed after 1 dose with the messenger RNA vaccine, that high efficacy will also be achieved with this vaccine. But of course, we need to wait for the data and see that in effect. And that may very well allow for an emergency use authorization filing in the end of the month of January or early February. And we're working hard with the company to make sure that vaccine doses that are actually produced and that will be physically there and filled in the month of February can actually be released from a regulatory standpoint because of the facilities in which they are produced or fill finished. And that's work that's ongoing with the FDA as we speak and J&J. If that was to be achieved, that can be quite a significant contribution to the vaccination of the population in the month of February and then even more in the month of March. So I think the likelihood that 100 million people will be immunized by the end of the first quarter of 2021 are very high. And then the second 100 million options that we now executed with Moderna and with Pfizer should allow in itself to immunize another 100 million individuals during the second quarter of the year 2021. In addition, J&J, Janssen's vaccine can significantly further increase that number. And, we'll see what the AstraZeneca trial brings. That's very likely to read out and allow for an emergency use authorization probably end of February or early in March. And then probably more in April, we'll have an EUA of the Novavax vaccine, and maybe in May, an emergency use authorization of the Sanofi vaccine. This is how we plan. There's a significant redundancy as we start the second quarter to achieve the next 200 million vaccinees. And as I said last time, about 80 million of the population is below the age of 18. For those indication at this stage, only the 16 to 18 years of age is approved for the Pfizer vaccine, and trials are ongoing with Moderna and actually also with the Janssen's vaccine. And those may actually go somewhat later into the summer because their approval may be slightly later. Thank you.
Operator, we have time for 2 more questions.
Great, thank you very much. Our next question here will come from Erica Edwards with NBC News. Erica, your line is now open.
Hi, thank you so much. It's Erica Edwards with NBC News. I'm hoping you can clarify something. And I apologize if Dr. Slaoui addressed it. His audio is a little bit garbled. I don't know if there's any way to fix that. But if I understood correctly, the original projection was to vaccinate 20 million people by the end of this year. It seems like 20 million vaccines will be delivered, which is different from actual shots in arms. Is there now a change in the projection for how many people will indeed be given that first dose by within the next week or so? Thank you.
Dr. Slaoui, go ahead.
The commitment that we can make is to make vaccine doses available and really to give at least the first shot of the vaccine, because by definition the second dose was going to fall in the month of January, obviously. And I think that commitment is met. Exactly how fast the ramp up of immunization, so shots in arm, is happening is slower than we thought it would be. And as I said earlier, we're here to help the states to accelerate that appropriately. So that objective is not met is unlikely to be met. 20 million people with a shot in arm, maybe we'll be surprised.
Yeah, we'll have them allocated before the end of the month, as Dr. Slaoui said, and then the last 5 million will be delivered the first week in January, and then uptake from there. So really, I think strong message in that we're getting the vaccines out as fast as they are available. Thank you.
Thank you. And our next question here will come from Candace Troy. And Candace, your line is now open.
Hi, Dr. Slaoui, can you clarify what is being explored for the Moderna dosage? Is the idea that people would only be given 1 dose possibly? And how quickly will you know, how soon will you know if that's possible? And is that being explored for Pfizer as well?
Well, I mean, as I expressed a few more other times, I think giving a 1-dose vaccine is totally inappropriate at this stage. Why? Because the data we have generated is with 2 doses. We know that the second dose increases the strength of the immune response about 10 times in terms of antibody response. We know that memory is installed much stronger, in a stronger way after a second dose. The immune system is designed to learn the first time it sees an antigen, and then to really burst when it sees it again. That's exactly what we do when we give 2 doses, and then we give boosters every year, every 2 years, every 5 years. That's how the immune system is designed to work. And therefore, pursuing a 1-dose strategy with something where the half-life is short is I think, something that should be tested experimentally, not inferred, because we see protection for 14 days or 7 days in the Moderna or the Pfizer trial. And by the way, that's exactly the question we're asking with the Janssen's vaccine. And in particular, I think I said that before, the Janssen's vaccine, its biology is such that actually the immune response continued to go up even after 90 days after immunization, in contrast to almost all protein and messenger RNA vaccines. Now, what we are exploring is to take advantage of that second dose very significant boost of the response and decrease the immunization dose. And you can achieve, again, twice the quantity of vaccine, volume of vaccine we have by giving 2 doses of 50 micrograms, for instance. And in phase 2 trials of the Moderna trial, for instance, the data obtained have suggested that the 50 microgram dose and the 100 microgram dose are substantially equivalent, particularly in people that are not very old. And therefore, that is an avenue that's being explored and discussed with the company and with the regulators. On that, I'd like to, in the name of all people in the operation, thank all the people into the operation that have participated, the thousands or tens of thousands of people in the manufacturing sites, in the laboratories, in the various agencies, in the private companies, Moderna, Pfizer, J&J, AstraZeneca, Novavax, Sanofi, and GSK, but also all the manufacturing companies, and critically, now well over 100,000 subjects that have volunteered into the clinical trials that are ongoing into the US. Merry Christmas, Happy New Year to everybody, and we look forward to significant progress being made between now and our next opportunity to brief you. Thank you very much.
Ladies and gentlemen, thank you for joining the call today. Please direct any unanswered questions to media@hhs.gov and have a happy holidays. Thank you very much.
In this new normal. My daughters came up. It was all great. Dog gave me a bone. We have a special guest with us today, Dr. Anthony Fauci. Dr. Fauci, I like to call America's doctor. He was probably the singular voice, in my opinion, as a medical professional who offered guidance and facts and clarity to people all through this, countrywide, worldwide. He always stuck to the science. He always stuck to the facts. He was clear when it was difficult news. He offered the facts. He did it in a way that was calming, but was truthful. And that's a hard balance, but he did that extraordinarily well. He's also been very kind to me. I've spoken to the doctor many, many times throughout this situation, and he's given me great advice and great guidance. He was also very helpful to New Yorkers on a personal level. He was very helpful to my brother Chris when he got COVID early on, gave him good advice. But the doctor has been a great, great friend to New York. I'm just worried when the doctor sends us the bill for all the consultation that he gave us. But you know what, doctor, maybe you could take the, just to ease bookkeeping, you take the Cuomo consultations, me and my brother, put them together on Chris's bill, send Chris the bill. He's a very generous person, my brother Chris, so I'm sure that'll be fine with him. Doctor, let me give you a sense of where we are and give you the facts today, and then I'd like to ask you a couple of questions to get your advice on where we go forward as this situation changes. Our positivity rate today, without what we call microclusters. Microclusters are the high problem areas in our state, which we have localized, and we have special strategies in them. And they have a higher percentage rate than the rest of the state. They're small zones, but they're intense positivities. Statewide, without those zones, we're at 4.2. If you add those zones in, we're at 4.7. The positivity in those high intensity zones is 6.5. We did 152,000 tests yesterday. On a Sunday, tends to be our lower testing day, but we still did 152,000 tests. 80 New Yorkers passed away. They're in our thoughts and prayers. 160 additional hospitalizations, 22 ICU, and 13 intubations. Our RT, we estimate at about 1.2 now. When you look across the state, you see a very varied picture. This is number of people who are hospitalized, and we look at the percent of the population that is hospitalized. So, for example, the highest percent of hospitalization is actually upstate. Finger Lakes, that's Monroe, Rochester area, Buffalo, Western New York, Central New York. You come down to New York City, Long Island, we actually have a lower rate hospitalized than upstate, which is an exact flip of where we were in the spring. Spring, we had a largely downstate situation, and upstate, the situation was much better. New York State, we've done a couple of things that are different than other states. In New York, the state sets all the policies on close down. The state keeps numbers that are determinative of the policies. We don't do it on a county or a city level. This, to me, avoids what I call the hodgepodge effect. Hodgepodge is a technical medical term that we have here in New York. We also apply it to government. Hodgepodge, just a discoordinated mess. It also reduces forum shopping. You know, when you see states where one county's open, one county's closed, you want to go for dinner, you go to the neighboring county. You want to go get a haircut, you go to the neighboring county, which only increases the number of people traveling, which is exactly what you don't want to do. And it reduces the confusion. We're also then taking it to the next level. We try to coordinate with surrounding states. So if I'm going to close restaurants, I try to coordinate it with New Jersey, Connecticut, et cetera, because if I close a restaurant but you live in Brooklyn and you can drive to New Jersey, then all I did is increase the traffic in New Jersey. It's not a perfect coordination, but in lieu of a national set of firm guidelines, which is frankly what I would have liked to see, we have come up with a regional compact of guidelines. We have been very transparent and communicative with New Yorkers. We have websites. I give them numbers every day. I wanted them to hear the facts. If anything, I've been accused of being overly communicative, especially at home. But the more facts people know, I think, the better. And we have been religious about following the data and the science. We do more testing than any state in the United States by far. We have more data points by far, and we rely on the data. And it's not anecdotal, it's not political, it's not an opinion. And we also started something called the Surgeon Flex Public Health System Management, which is something we're going to be implementing in an increased way today. Surgeon Flex is not the most creative name, but what it says is we surge and we flex the hospital system in the state. We start with 54,000 hospital beds statewide. We can then mandate by the Department of Health, Dr. Howard Zucker to my left, Jim Malatras to his left, Gareth Rhodes to my far right, Melissa DeRosa to my right. You know, Dr. Zucker and Melissa, you've worked with them. But Dr. Zucker can order a 50% increase in beds, which we've done before. Dr. Zucker can order no elective surgeries, which we have done before. And we can create field hospital beds, which we've done before, and we can create several thousand field hospital beds. So when you look at our hospital capacity, we start with 54,000 beds. You can increase it by 50%. Takes you to 75,000 total bed capacity. Roughly 35,000 of those beds are now occupied. If you cancel elective surgery, we estimate that you reduce the number of occupied beds by about half. That takes us to a total system capacity of about 58,000 beds for COVID patients. Today we have 4,600 hospitalized. So that gives you a range of the capacity for the system. We can also add 5,000 additional field hospital beds. That would be, from my point of view, the last resource. We did that. The Jacob Javits Center, for example, we did 2,000 beds. Dr. Fauci, it looked like a field hospital in an army. You just saw an ocean of cots. And I just hope we never have to get to that point. Today, the Department of Health is going to issue an order saying hospitals have to increase their bed capacity 25%. We can issue up to 50%. They can do that physically, but we're only going to go to 25% because we don't have a capacity criticality at this moment. We are aware of staff resources. The staff comes into this stressed, right? You want to talk about a long year. Nurses, doctors, hospital workers, 1199, they had the longest year of anyone. So they come into this stressed. We're going to ask retired doctors and nurses to sign up, and we will automatically re-register them in the state without cost. We believe we can get about another 20,000 nurses and doctors from this mechanism. And then the flex on the surgeon flex is we have 215 hospitals. What happened in the spring, interestingly, was not that the system was overwhelmed, individual hospitals got overwhelmed. And the individual hospitals did not have the capacity to balance patients. Frankly, this was an education for me. So you have public hospital systems. And let's say you have a public hospital system that had 10 hospitals. One hospital gets overwhelmed. They did not have the capacity to balance those patients among their other 9 hospitals, right? So even in the public systems, before somebody walked into one hospital that was already overburdened, they didn't say, hold on, I'm going to put you in an ambulance and drive you to my sister hospital that has less volume. What our flex says is those hospitals have to flex patient load and share it first within their system. We also shift patient load among private hospitals, which was frankly more unorthodox, right? You go to NYU Langone, you think you're going to NYU Langone. What we say on the flex is if NYU Langone is filled or at capacity, we're going to transfer you to Mount Sinai or another hospital. And then we actually have the capacity to shift between public and private systems. None of this has been done before. It was highly disruptive for the hospital management system. But we started it in the spring. It went fine enough, and we now have had more experience in it. We've started the flex management system, where every night we get an inventory from every hospital doctor. How many patients do you have? How many ICU beds do you have? What capacity do you have? And we do that on a daily basis. If our hospital capacity becomes critical, we're going to close down that region. Period. We call close down a red zone. What is critical hospital capacity? Our formula is if your 7-day average shows that within 3 weeks you will hit critical hospital capacity, we close you down. So if your 7-day average says if that continues for 3 weeks, you're going to hit critical hospital capacity, we close you down. We want that 3-week buffer. And then we call critical 90% of your hospital capacity. So a little complicated. If your 7-day average says if it continues for 3 weeks, you're going to hit 90% of your hospital capacity, close down. CDC changed their guidance on Friday. Some have been critical about the changing guidance from CDC. I'm not. I believe as the facts change, your opinion changes. As the facts change, your strategy should change. I don't have a problem with that. But they offered additional guidance on indoor dining, especially. And we're going to follow their guidance. If after 5 days we haven't seen a stabilization in a region's hospital rate, we're going to clamp down on indoor dining. 5 days, if the hospitalization rate doesn't stabilize in New York City, we're going to close indoor dining. We're now at 25% in New York City. In the rest of the state, any region where the hospitalization rate doesn't stabilize, they're now at 50% capacity indoor dining. We're going to go to 25%. We have zones that are called orange zones where it's already closed. That wouldn't apply here. Bottom line for us, I see it as hospital capacity versus vaccination critical mass. I think that's the ultimate bottom line. Can your hospitals handle the increase until you start to see a reduction from the vaccinations? On the hospital capacity, do everything you can do to slow the spread, and then at the same time accelerate the vaccines. The frustrations we're seeing here, we estimate over 70% of the spread is coming from small gatherings, and that's a problem. We're going to go through the holiday season. I think there's going to be more small gatherings. I've been talking until I'm blue in the face about the apparent safety of being at home, the apparent safety of being with your family, but that can be misleading. Your brother, your sister, your mother can love you, but they can still infect you. I know you think you're sitting in your living room and you're safe, but your living room is not really a safe zone. This isn't a political question. Trump's CDC and the Biden advisors all agree on the small gathering guidance. But it's about personal responsibility and community concern, and I'm telling you, compliance is a major issue for us here. I'm also frustrated that we see polls that suggest a high percent of Americans are not ready to take this vaccine. 49% nationwide. Bigger problem in the black community. 57% say they're not ready to take the vaccine. But 75% to 80% needs to be vaccinated to hit critical mass on the vaccination. And that's a problem. If you have 50% saying I'm not taking it, but we have to hit 75 to 80. The good news is New York still has one of the lowest positivity rates in the nation. Only Maine, Vermont, Hawaii are lower than we are. And Maine, Vermont, Hawaii, beautiful states, but different than New York. They don't have the cities, they don't have the density, etc. So for us to be down that low is really good news. As a matter of fact, our worst region, our highest region in terms of positivity, is still lower than 41 states. So it's tricky because relative to everyone else, we're doing well, but the real question is, it's not a relative contest at the end of the day, it's how you're doing in your state. So to recap, we're going to monitor the hospital capacity. If it doesn't stabilize, We're going to reduce the indoor dining restrictions. We go to zero New York State, 25% everywhere else. We close down if you hit critical hospital capacity. We're implementing the surge and flex. We're going to add 25% additional hospital beds. Renew the registration for nurses and doctors to get us a backup staff pool. Continue to caution on the small spread. And at the same time, we are gearing up to have the most efficient, most effective, most fair vaccination program in the country, reaching out to the Black community, Latinos, undocumented, to make sure that it's fair. So a couple of questions for you, Dr. Fauci. That's what we're doing. In general, your opinion has always been valuable to us. The holiday spread, I think it continues through Christmas, Hanukkah, etc. Trying to guess, and I know it's a guess, when we could see a peak to this holiday spread. Is it after New Year's? Is it January, mid-January? Do you have any guess, educated point about that? And again, thank you very, very much for being with us.
Well, thank you very much, Governor, for giving me the opportunity to listen to what I found to be a very interesting plan that you have for New York. It seems really sound, and you have a lot of, backup contingencies, which I like. So you're not going to get caught shorthanded on this, I'm certain. So thank you for that. With regard to the issue of the holiday spread and the peaks, they're going to be superimposed upon each other. So you would expect the full blunt of the travel and the family setting gatherings with friends that you alluded to as being a problem. You'd expect that the effect of the Thanksgiving surge would be probably another week and a week and a half from now, because it's usually 2.5 weeks from the time of the event. The problem is that's going to come right up to the beginning of the Christmas Hanukkah potential surge. So you have a surge upon a surge, and then before you can handle that, more people are going to travel over Christmas. They're going to have more of those family and friends gatherings that you accurately said are an issue. So if those two things happen and we don't mitigate well, we don't listen to the public health measures that we need to follow, that we could start to see things really get bad in the middle of January. So I think not only for New York State, but for any state or city that is facing similar problems, without substantial mitigation, the middle of January can be a really dark time for us. But as you said in your presentation, Governor, there are some things that we can do to mitigate against that. I think particularly the appreciation that it's such a natural thing to think when I have family and friends over for the holidays, Christmas and Hanukkah, you get indoors, you take your mask off because you're eating and drinking, and you don't realize that there may be somebody that you know, that you love, that's a friend, that's a family member, who is perfectly well with no symptoms, and yet they got infected in the community and brought it into that small gathering that you're now having in your home. So that's the reason why I want to underscore what you said. That's one of the issues. But bottom line for your first question, mid-January is probably going to be the bad time.
The small spread, family spread, living room spread, we call it living room spread here. So like 16 states have done an order of no more than 10 in a home. CDC guidance, that's President Trump's CDC, says no more than 10. Some states have gone to no more than 8. People, compliance is very low on that. Do you think that is a sound rule, that no more than 10 in the home?
Governor, I think that's a very sound rule. And I feel, 10 may even be a bit too much. it's not only the number, Governor, but it's the people who might be coming in from out of town. You mentioned in your presentation how you don't want somebody who's from New York who wants to go to a restaurant that's closed in New York. They go to New Jersey and then they come back. They've traveled back and forth. In addition to the absolute number of the people in a home for a gathering or a social setting, you want to make sure you don't get people who just got off an airport or a plane or a train and came in from Florida or came in from wherever. That's even more risky than the absolute number. So not only the number of 10 seems reasonable, but make sure that when people come in, that they're not people who you have no idea where they've been or who they've been exposed to. I mean, you want to be friendly, you want to be collegial, but you really got to be careful about that.
Yeah. No, you're so right, Doctor. And the practical implications are so difficult. As I mentioned at a birthday yesterday, one of my daughters who wasn't with me, who wanted to come up, she had a quarantine before she could come to my birthday, you know. So you want to go travel and see someone, it's not just that weekend. It's the whole quarantining process before. And in this state, we have very strict regulations of when you come in, what you have to do. On the vaccinations, looking ahead, 75–80% is going to be very hard to reach. New Yorkers are tuned in, and we're going to be very aggressive on public education, outreach, et cetera. But what does your crystal ball say? When is 75–80 even feasible? You know, I hear anywhere from May, June, July, August, September. What would you guess there? Which is when it's really over, right? When the vaccination hits critical mass.
Yeah, when you have 75–80% of the people vaccinated, you have an umbrella of protection over the community, that the level of community spread will be really, really very low. The virus will not have any place to go. It's almost metaphorically, if you think the virus is looking for some victims, when most of the people are protected, the virus has a hard time latching on to someone. When that happens, Governor, is going to be entirely dependent upon how well we do, how well I do, you do, your health officials, in getting the message out of why it's so important for people to get vaccinated. Because if 50% of the people get vaccinated, then we don't have that umbrella of immunity over us. But let's say it works out well. Now, let me answer your question specifically. And we do a really good job of convincing people. Between now and the end of December, you would likely get a substantial proportion of healthcare providers and people in your nursing homes. As you get into January, you'll get the second level, and then February 3rd. I would think by the time you get to the beginning of April, you'll start getting people who have no high priority, just a normal man and woman New Yorker in the street who's well, has no underlying conditions. If we get them vaccinated in a full court press, get them really going, and you do that through April, May, and June, by the time you get to the summer, because remember, it's a prime boost, which means you get vaccinated today, you get a boost 28 days from now,